Okay, as I mentioned. All right. So as everybody sees, we do have a little red light that indicates we are recording this presentation. That is so people who are unavailable to make this presentation will be able to see it on the BRA Group's website in about a week or so. So if you do not want your face shown on camera, we're happy for you to turn your video off, but we'd love to see your beautiful faces if you're willing to share them. So this Zoom is presented by Breast Cancer Recovery in Action. We are a Nashville-based nonprofit. Our programs include exercise education, which is presentations like BRA Banter and our Healthy Habits Nutrition classes, and emotional wellness classes. So if you're already not a member, we would love to share more about our programs if you want to get in contact with us. We ask all of our participants who are in this class or on this presentation to please keep your mics muted when you're not sharing. That avoids background noise. So that's one of our housekeeping informational topics. And if you want to get in contact with us, say this is an informal Zoom. So we do encourage you to participate, ask questions if you would like to. Just raise your hand, wave at us, or you can use the Zoom chat feature. So we're happy for you to participate. Just try to make sure that you're not interrupting any other person who currently has our wonderful speaker's attention. So with that, I am going to turn y'all over to Jahan, and she will be introducing our two guests today. Once again, thank you for joining us.
Hey, it's so good to see all of you. And like Lynn said, I have the privilege of introducing our guest speakers. So we have two fabulous women, both scientists. Let me start with Dr. Ashley Henneghan. She's at the University of Texas in Austin with her PhD. She is an assistant professor of nursing there. I asked her for, well, I'll let her tell you more about kind of how she got into this research, but I asked her for a fun fact, and Ashley raises seeing eye dog puppies and just graduated her first pup in June into the workforce and is now training her second puppy named Tink after her grandmother. Is that right? I love that. So sweet. How long did you have the first puppy?
About 16 months, I think. Yeah,
Okay.
almost a year and a half. It was a long time. And it was, if everyone's like, how do you do it? I'm like, I don't know how I did that one. I knew it was going to be hard, but it was actually way harder than I thought it was going to be. But seeing it come full circle, like she was my first, so it was definitely, you know, a whole thing. But seeing it come full circle and meeting her handler who she's now living with, and just, you know, getting that experience really kind of made it worth it. And I was like, well, I'll try it again. Maybe it won't be so hard the second time. We'll see. But this time I'm working with an organization out of Texas, so it's a little bit less of a traveling, and the other one was in California. So it was a little to get her to and from, and this one's in San Antonio. So we'll see how it goes. They also
quite
let
a
me,
commitment.
yeah.
Quite a commitment, but it sounds like it's pretty rewarding. I can imagine that would be, I can only imagine how proud you were when your pup graduated.
Oh my gosh. Yeah. So proud.
That's amazing. And then our second speaker that's going to also be working with with Ashley today is Dr. Kathleen Van Dyk. Am I saying that right?
That's right.
Okay. And she is a clinical professor, PhD researcher at UCLA in Los Angeles. And when I asked for her fun fact, she said she likes mysteries and she goes through about one a week in her free time, which I love. That's so interesting to me to hear what people do when they're not at work.
With a child. You
with
mentioned
a daughter.
That's
That's right.
I mean, as you mentioned, I live in LA, so I do have some commuting time.
You got time to read. That's good.
You got time to get some books in. Yes.
So we are so thrilled to have you ladies speak to us today. We're really excited to hear about the work that you're doing and just some of the things that you've discovered as you treat patients in the clinic and as well as in your lab. So I'm going to turn it over to you and kind of let y'all share. I was just going to, as an opener to kick us off, one of you's in Texas and one's in California. So I know one thing Lynn and I originally wanted to know is how did you guys get together and kind of how did it come about that you started working together on this research?
Sure. Yeah. Well, we started working together after meeting at a conference. the world of, I guess, cancer and cognition research is kind of small. Like there's not that many people who do that, this research. At least there's more now, but back 10 years ago or however long it was ago that we got into it, there were less. So you go to this conference that we have called the International Cancer and Cognition Task Force that meets internationally every 2 years. And we, I think we were chatting during the poster session together. And I was really interested in some of the work that Kat was doing. And then since then, we've just enjoyed working together. We have similar, like we kind of approach this topic pretty similarly and to work together. We've been pretty productive, I think, over the past couple of years, but
Yeah, no, and as a neuropsychologist, I really love working with nurses. And the perspective that Ashley brings to the patient care and the patient perspective is, really well aligned with kind of the psychologist in me that's working with these patients as well. So I think our philosophies around the work and how to approach it and how to help patient care just align really well. And she's really, really nice and fun to work with too.
Great.
this Kat.
Well, technology is amazing, right? I mean,
Yeah.
it enables your relationship to.
No, for sure. We actually started working together during the pandemic, mostly.
Mostly. Yeah, 2020 we started doing more together. Yeah, now we have an active grant together, so we try to meet now every other week to do a couple hours of just getting ideas together, maybe doing some data analyses, getting papers together, thinking about the next grants and things like that. So we've become more regular with how often we work together, which is great, being so far away. But yeah, Jihadi, you had mentioned in the intro, like that we would talk about how we got into this type of research.
Yes.
So actually, Kat, I don't know how you got into the CRCI world.
Well, I actually come from a dementia and aging background, so I always thought that I would work with older adults for the rest of my life. And then when I started working at UCLA, I was introduced to an oncologist named Patty Gans who said, "Oh, you're a neuropsychologist and you're interested in women's health and you're interested in aging related things. We really need more researchers and clinicians like you in the cancer related cognitive impairment space. Let me bring you over to my side and start to do research." And so Patty became one of like my primary main mentors in this area. And I just really recognized how much need there was both locally, clinically around here, and just more broadly in terms of what we know about cancer-related cognitive impairment and cancer-related cognitive problems. And it just seemed like a very important area to pursue, with a lot of need for a lot of folks.
Yeah. Interesting. Yeah.
Same question back to you, Ashley.
Back to you.
As when I practiced more as a nurse, I was mainly a palliative care nurse. So I focused on quality of life, symptom management, and that was always kind of the bread and butter of what I cared about in nursing. And when I went back to get my PhD, I kind of assumed my research would go in that direction. But in some of my coursework, I got placed out in a community oncology clinic, and they needed some help kind of putting together patient education materials on the late and long-term effects of breast cancer treatment. So I was like, oh, this is interesting. And the more that I learned about it, this issue of cognition just seemed to be, this was in 2012. It was like, oh, there's so little that we know about this. And it's such a big deal. And I just think that there's a universal, thing that we all value, like we identify with our cognitive abilities so strongly. It's everyone's worst fear, to lose those. So even though I haven't been through cancer treatment personally, I can identify with that, the how important it is and how important it is in everyday life, in terms of getting through the day. So yeah, I became pretty passionate about that. And then I changed my topic pretty early in my PhD and have focused on this since then. So yeah.
Really interesting. It is true. When I was going through treatment, every drug I did, there were extensive releases that I had to sign where I was made aware of all the potential side effects. But I don't really remember hearing a lot about cognitive side effects. Neuropathy came up, all sorts of heart issues. I mean, I was screened for so much. But nobody really mentioned, cognitive issues. And I don't know if it's because they weren't documented or if, I'm just not sure what it is. Maybe I missed those. I don't know. I wasn't worried. I was like, I was young. It's not going to be an issue. But I just remember extensive conversations about nerves, heart, all sorts of parts of my body, but nothing about my brain.
No, and I still unfortunately think that that is the case today, where there's not enough of a lead-in heads up that this could be a problem.
Right.
You know, I have heard from women when we've discussed this topic in the past, frankly, that some women wouldn't want to know that there
Right.
are problems later. Totally fair.
Yeah.
But others would like to have a heads up, and certainly, you know, I think it should be part of the informed consent process because the rates are really high.
Right.
And that, and you know, just like neuropathy, right? Like if there's a proportion of women who are getting these problems, then we really need to give people a heads up about it because it really affects their life later. When they're finished with treatment, they try to go back to work, and that's where they start to see a lot of the problems that maybe weren't as apparent, you know, while they were undergoing treatment and recovering, which is what we hear a lot clinically.
I wonder too how underreported it is after treatment is over, because I feel like a lot of people that I talk to, and just I know for myself, I'm more likely to go into my oncologist and tell him about my joint pain or about my weight gain or sort of these things that I feel like are like outward appearance, right, pressing in my face all the time. But over time, I've started realizing I feel like my brain is foggy. I'm struggling with word recall, but it's like it's taken me longer to even think about that being connected to the treatment. And therefore, I didn't tell him about it as early or as passionately, you know what I mean? So I just wonder even if the doctors aren't getting that from their patients either as often.
Yeah, that is a very good point. One of my favorite, and it's not a favorite in the good sense, but just one of, I think, the most impressive statistics that I like to share is that the sister study and the two sister study of breast cancer survivors, and this came out, I think, in 2018. And what they found was that in the year after treatment, I think around 2/3 of women reported problems, but only 1/3 of women with cognitive problems had talked to their doctor about it,
Mhm.
which is just so telling in terms of how little this gets discussed. And
Right.
if it's not spontaneously reported, then it's not necessarily the case that the doc is going to ask about it, even though at this point we have recommendations like through NCCN about asking patients about how their cognition is, right? We're doing our best to make sure that it's more well known, but it's still something that gets overlooked.
Yeah.
Yeah, we've got a comment from someone from Brittany on our call who was very young when she was diagnosed in her 30s, and she said it also tends to be dismissed when it's brought up because a lot of times the doctors might say, "Well, you just turned 40, you know, welcome to my world," kind of thing.
Yeah, I was gonna
Oh,
mention that
yes.
too. Just like it's either not discussed or when it's brought up, it's yeah, dismissed or it's explained like you're probably just depressed or explained by as something else and not really taken seriously.
Right.
And I mean, I don't know what that is all about in terms of medical oncology, but it really medical oncology is about medicine and there aren't any medicines to cure CRCI. So maybe there's something around that. Like they don't have something they can prescribe to make it better per se. But I mean, I don't know if Kat has any insights on that.
Yeah. No, yeah, it's so unfortunately common to get that kind of response,
Yeah.
and so invalidating. And with some of the patients that I've talked to, really traumatizing because they're like, here's an issue that I'm having, and they're just like, nah, you're fine, or
Yeah.
nah, it's aging. It's like, no, 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 I'm different, and I know it, and you can't tell me that I'm not experiencing what I'm experiencing. So I've
Right.
had to unpack a lot of that with patients when I see them, and yeah, it is. I agree with you, Ashley, that I think partly there can be a kind of reluctance to talk about it because there isn't an easy fix. Um,
Right.
but as we do more clinical work, and so as I've talked to more oncologists, I suspect that they're asking more patients about it so that they can send me referrals and that there's a place to go, there's something to do. So as we build clinical services around this issue, hopefully that would be mitigated.
Yeah, definitely. Actually, I was curious how, at UCLA Cancer Center, like how do patients get referred to you? And then what does it look like when you are treating a patient for CRCI?
Yeah, that's a great question. So I honestly kind of like really build this from the ground up because there weren't a lot of people working in this space. And so I initially just started kind of seeing patients for straight up assessment, just assessing their cognitive problems. And as we all know, and we may talk about a little bit more later, but when people come in with with cancer-related cognitive problems, they don't look like someone who has Alzheimer's disease. They don't look like someone who has a type of dementia or who has a serious head injury. The cognitive problems are typically more subtle, and so our tests aren't always the best at capturing that. And so while I was starting to just converse more, just dialogue more with the oncologists around UCLA and talking to them about what I was trying to do, the patients that I was seeing, I would have to do a lot of really kind of fine-tooth combing of their cognitive performance to understand what their strengths and weaknesses were, and to try to help explain to them that even though they're performing okay on this test, that I still believe that they have changed, that there are problems. It's just that this is our fault. This is our test problem, that we're not picking this up appropriately or accurately. And then I kind of shifted after working in that space for we're just doing straight up assessment for a while to try to bring in more cut rehab, just try to help folks say, okay, well, I do have these problems. I don't have dementia, right? I don't have significant impairment, but I am struggling. What can I do to overcome this in day-to-day life and in work? And so then it really became about kind of like a cognitive rehabilitation approach, where it's like, well, you have these strengths, let's leverage these strengths to support your functioning in day-to-day life. Even though you aren't doing the things the exact same way, how do you still get to point B? How do you still get to your goals? Even though you are experiencing a little bit more fatigue, a little bit more fogginess, a little more attention problems. And then it kind of, I haven't done much advertising, to be honest, because I'm only a one woman show. And I've got a lot, going on, but, I think there's certainly been real buy-in with the oncology community around here to recognize this. And I've given talks, and I've partnered with our local psychosocial medicine group to give talks, rehab type workshops and things like that for our patients. So just building awareness.
Got it. Yeah, I think it's interesting because, I did my postdoc at MD Anderson, which is like a huge cancer center. And so there's an entire department of neuropsychology, and that was kind of built into the routine care for a lot of patients that go to MD Anderson, which kind of brings up the bigger issue of the difference in oncology care in comprehensive cancer centers versus community oncology clinics and what resources are available. And I think that it's just knowing that neuropsychologists, exist as a profession, and that just maybe seek out one in your community is, if you are really concerned about your cognitive abilities, to do some formal testing and then maybe start an individualized cognitive rehab plan is something just to know about, that I think when I'm talking with people in the community, they don't necessarily even know about that.
Well, and also I would say, so I go to Vanderbilt here in Nashville, and as I have passed through, years after my cancer diagnosis, right? When I go in to see my oncologist, the conversation is really geared towards recurrence, right? They're screening me for recurrence, not as much towards symptoms from treatment. I actually am treated for most of those issues by my internist. And that's a whole different ball of wax, right? Having all of the internists in the world educated on how to manage, right, these issues. She's the person actually that I actually do have neuropathy from treatment. She's the person I deal with that, and ended up referring me out. But most of my ongoing treatment for side effects is definitely moving out of cancer clinic. And it's just in those early days, they're very focused on recurrence, right? And they're busy because a lot of their patients are in active treatment or are being diagnosed. And so I'm not sure how that is everywhere. But I also knew people who went to MD Anderson for treatment. But then once you're done, you're staying at your home base, right? You're not traveling there all the time for ongoing assessments. So I think that partially is responsible for this lapse.
That's a really good point.
And I feel like I have excellent care, so I'm not saying anything negative about Vanderbilt, but it's just who's taking care of you once you're through that real crisis.
Well, and frankly, at this point, a lot of the patients who eventually do get followed up for these issues are the ones who are self-advocating.
Right.
Additional support, additional treatment, additional assessment, which shouldn't be the case, right? Everyone should be offered and assessed, but that's just the reality right now.
Interesting. Would you mind elaborating a little bit more? You talk about CRCI. And so in our world, a lot of people talk about chemo brain, but
Mhm.
I know that you two view it as not just from chemo. Could you elaborate for our participants that there are other treatments and issues that you feel like are contributing to these cognitive issues?
Yeah, definitely. Like you said, this is commonly known as chemo brain and chemo fog, because, chemotherapy is such a, likely contributor to, to people's cognitive abilities or dysfunction following, cancer treatment. But we have learned over the decades that these symptoms can arise before treatment even starts. So it's not just the chemo, it's not just the treatment per se. There might be something about the cancer pathology, the psycho-emotional response to such an extreme diagnosis. And really, there's a lot of different factors that contribute to CRCI is what we call it. So yeah, we've evolved and started calling it cancer related because it's not necessarily the treatments. It's something related to the cancer experience that results in, these cognitive changes. Something is different than what it was right before the treatment or the diagnosis even started. And we have a blog. I think you shared it in one of your communication channels that we recently did in partnership with Keep Abreast, another nonprofit in California, that we have a nice visual that I would share if you'd like me to walk
Yeah.
through some of these.
We enabled.
Yeah, you should be able to
Zoom, so
share
you
it.
should be able to, there you go.
Great. Let me use this over here. So this, can everyone see it okay? Is it big enough? A little bit bigger?
Maybe a little bigger, yeah.
Okay. Oops. Trying to move it over. Still bigger, or like I might not. Do you want me to make it bigger?
Maybe a little bigger.
Okay.
Can I blame my need for readers on cancer also? Or is that just me getting old?
We're
Move.
I was gonna say, yeah,
called
please.
cancer card, and
I can read
I
that.
think you're
now.
a little too far out. That expired a few years ago. Hugo.
Yeah. So is this picture big enough?
Yeah, that's good.
Okay.
That's
I'll
great.
screen over, but if I go bigger, I
At
can't
one
do it.
point, you were getting really far to the side, but now we're good. Yeah.
Yeah, awesome. So there's this little, infographic because it kind of shows the brain and then it broken into segments. And these are not all of the factors, but these are kind of some of the main factors that we focus on in the research right now. But it just shows that all of these parts, all these different, pieces make up, brain function. And primarily breast cancer and cancer treatments are a factor. Lifestyle, kind of biological general inflammation and stress on the body, contextual factors, and genetics. So I'm going to move over now and kind of walk through a few of those a little bit more. So in terms of breast cancer and treatment, we have the key players here in terms of chemotherapy, radiation, surgery, anti-estrogen therapies. And the largest body of evidence kind of supports the chemotherapy connection in terms of comparing people who have had chemotherapy compared to those who have not had chemo compared to controls. The chemo group tends to have the worst. However, the people who are in the no chemo but have other cancer treatments are also usually worse than the control group. So again, cancer related cognitive changes. So breast radiation, so having radiation in your chest wall can kind of trigger an inflammatory response and some oxidative damage that can happen out, in the body, but then kind of go up into the brain and, kind of interact with different brain and cognitive processes up there. So just general surgery with anesthesia. Anesthesia is a cognitive risk factor. That's just for anyone going into a surgery. So considering that a lot of times breast cancer treatment involves, primary removal of tumors and reconstruction, or maybe multiple reconstruction surgeries, that's just something to consider. And then anti-estrogen therapies. Estrogen is really important in our bodies. It's very neuroprotective. And, people also talk about pregnancy brain or menopause brain. So when there are major shifts in estrogen, cognitive changes can happen too. And like I said before, the breast cancer itself, considering some of these impairments have been found before any treatment has even begun, there might be something going on with the pathology that makes the brain more vulnerable. Kat, do you have anything to add for this part before I move on?
No, yeah, I think, well, I guess one consideration too is that I think one of the reasons that chemotherapy was one of the first foci in this area, or there's a couple reasons, but one, the chemotherapies used to be a lot more toxic than they are now. And you typically will see kind of a relationship between undergoing chemotherapy and the experience of fog, whereas you might not see an immediate effect of something like an anti-estrogen therapy on cognition. You might not make that connection. We were talking about like connecting what the treatment is doing to my brain. You might not make that connection right away, or in the context of surgery or radiation, again, you might not make that connection right away. So it could be that later, a couple months later, you're starting to notice that things aren't quite the way they used to be, or you're not functioning quite the way it used to be. So it can be a little bit hard to pick out what that it might be going on, because it's not necessarily immediately a response to a treatment.
Right.
Mm.
Definitely. So there's some other factors that aren't necessarily related to the cancer diagnosis and treatment that can interact with the cancer related factors at the individual level. So things like comorbidities, there are certain chronic conditions like diabetes or autoimmune conditions or cardiovascular disease that can negatively impact cognition. So if you have that in addition to cancer, it makes your brain a little bit more vulnerable. So yeah, we see that there's some research that suggests that those with more comorbidities are at greater risk for CRCI. There have been some genetic links to CRCI occurring. There's, that makes some people who are born with these genes a little bit more susceptible than others. But I would say that body of literature isn't that huge. So there's not like one gene that we can link. There's just kind of this general APOE, which is in the dementia literature. That's kind of a broad, I don't know, it's more than, I don't know how to explain that, Kat. How would you?
Yeah, so that there's a specific genotype that puts someone at greater risk for developing Alzheimer's later in life. It's called the APOE4 allele, carriers of APOE4 allele. So there, and as Ashley was saying, there's not a really real strong basis of evidence to suggest that women with an APOE4 allele are going to be more likely to have cognitive problems in the context of cancer. And it kind of gets the fact, and we don't have good genetic predictors for who's going to develop cognitive problems in the context of cancer. Similarly, we don't really have a good predictive model. So we're not entirely sure who is going to have cognitive problems following cancer treatment, cancer and cancer treatment, which is something that we're continuing to look for in our research. But it's still, so it becomes more and more challenging to tell someone that you are or are more or less likely, because sometimes it just develops in very healthy women and you're not really sure why.
Yeah.
But we're still, the research is ongoing. So we're still trying to identify how to help figure out who's at greatest risk.
Yeah, definitely. And then in terms of this oxidative damage inflammation, so, when I was working on my PhD, I kind of really thought about this idea. And I know you've looked at biomarkers too, Kat, but just this notion that if there's, all of these people are going through the same types of treatments, and not same, but similar, but some have this problem and others don't, like what's going on in terms of like a biological mechanism. So a lot of the biological research has looked at, this kind of chronic inflammation or this dysregulation of inflammation in the body. So, inflammation is totally normal in a healthy body. It's adaptive. It's what we need to heal, to deal with illness and all of that. But if you're in a chronic state of stress, our endocrine system and our immune system, they work together. And if you have depleted all of your cortisol and your stress hormones, the whole system gets messed up, that can no longer keep things in balance. So there is some research that kind of supports that there's more oxidative damage and some inflammation at the cellular level in those who have gone through breast cancer treatment compared to controls. And there's been some links to CRCI, but not a huge body of research, but that's the most in terms of mechanistic stuff that we've found. So then in terms of, besides these these breast cancer treatment related factors and individual factors, there's also situational and contextual factors, in terms of how, think about having a bad night's sleep, that your brain functions differently when you're up with the puppy at 3 a.m. Doing potty training and then not sleeping the rest of the night. You function differently on a day-to-day basis for a lot of factors. And the most research that we've had so far kind of supports this link between stress, distress, like a stressed brain functions differently than a relaxed brain, pain, acute pain, chronic pain, and sleep, and how all of those factors can either enhance if they're in a good place or hinder your cognitive abilities. And then social support and connection, this idea of, we are social beings, and there's an epidemic of loneliness and disconnection going on, and the connection between, loneliness and poor cognitive functioning is pretty strong in the broader literature. So, and I've seen that in some of the studies that we do, looking at this connection between loneliness and CRCI specifically. It's important. And then lifestyle behaviors. As a nurse, we're very health promotion oriented, and things like physical activity, diet rich in nutrients and antioxidants, good sleep, and stress management will all bolster, cognitive functioning versus, hinder. And the other plus side of the lifestyle behaviors is that they're kind of recommended broadly for a lot of the late and long-term effects of breast cancer treatment, and also for decreasing the likelihood of recurrence too. So a lot of the research on behavioral interventions for CRCI have kind of focused on targeting these things in terms of lifestyle behaviors, or have been kind of a cognitive rehab, cognitive training approach to hopefully kind of tap into neuroplasticity and kind of creating new networks in people's brains. Stop sharing. It's a lot of things. Any questions on those? I feel like there would probably be some questions on that.
Yeah, if I could just add a little comment at the end too, is that I at least tend to think about both the contributing factors of things that are putting someone at risk for cognitive problems, and also the ways that we can help support cognitive health as like a Venn diagram of different abilities, right? So just like Ashley was saying, I see a lot of patients who have chronic pain, or who have peripheral neuropathy, or who have sleep problems because of their peripheral neuropathy, or are having hot flashes. There's a lot of different overlapping symptoms, and the brain is in our body, and so it's not separate. It's one system, and so we have to kind of consider all of everything that's happening in a woman's body, and how that could deplete from cognitive resources, from cognitive energy, or conversely, how we can support it by supporting the body.
Yeah, I was just going to say that those lifestyle factors and some of the things at the end, I mean, that's one of the reasons that the BRA organization was so impactful for me, because it does address some of those with like the nutritional education and the, moving your body, exercise, and community. But something, and again, this is just me, but I have really struggled with insomnia, because all the treatments have forced me into medical menopause, and there was no gradual adjusting the way it would have been if I had naturally gone in. It was like, boom, like here you are. And my oncologist doesn't want me to really take anything for sleep. And so that is an issue. I mean, chronic fatigue, when you are not sleeping well, I mean, when I finally go to sleep, I stay asleep, but it takes me forever to go to sleep. When I finally go to sleep, am I getting enough hours? And then over time, you're having a deficit there. I almost wonder if that's half of my problem. It's like if I was just getting well rested, it may not actually be cognitive impairment. I don't know how y'all quantify it, but it literally might just be chronic fatigue. But it's hard. That's where you're like, you don't really know, as you're just trying to make sure all these things are lining up.
Yeah, we look at the whole picture and see where you can intervene, where you can support. With insomnia, there's actually been some literature in the breast cancer population that cognitive behavioral therapy for insomnia can be helpful.
Okay.
So it uses the kind of techniques of cognitive behavioral therapy, which is psychotherapy that's effective in treating depression and anxiety, but it's not a psychotherapy. It's just using those techniques, and essentially tries to help a person create the most conducive environment and most conducive sleep hygiene practices for getting a good night's sleep, and squeeze the amount of time that they're in bed to just when they're sleeping, and then gradually increase it out, so that, really you're just making a very, very clean association between bed and sleep, bed and sleep, bed and sleep. And there's some apps that are out there. Like My Shut Eye is the one that I'm thinking of that has evidence behind it, but there's a whole bunch of apps for CBTI and CBT little I, CBT for insomnia.
Okay, that's great. I'll write that. Thank you. I do think it's helpful. I mean, I've learned just not to stay in bed and be stewing over how I'm not falling asleep, because then I'm ticked. My husband's snoring, the dogs are snoring, and then I'm just getting more and more mad, right? Yeah. So to get up and do something else is helpful. But thank you. I will look into that. I think the other thing I was just going to say is that Ashley, we're talking about stress and trauma. Like when you are diagnosed with something like breast cancer, there's that heightened worry that also contributes to a lack of sleep, right? There's just a lot of things you can't separate. We're complex people. You can't separate one from the other.
Certainly cannot. No.
Yeah.
No, absolutely. I mean, and a lot of the patients that I see, or not a lot, but a fair number of the patients that I see, we talk a lot about trauma and the experience of trauma and how that could be impacting their cognitive function, and how the experience of a cognitive lapse, a memory blip, can cause a person to, be a trigger for their experience of being diagnosed. It's like a reminder that they went through this process, a reminder of the negative experiences that they had, and try and separate those and disentangle those.
That makes sense.
That's actually exactly where I was going to go with my question is, I do feel like when we do our emotional wellness groups, we do come across like PTSD and survivors, right? And I was wondering, do you do like a lot of collaborations in your research with other areas? I mean, it seems like obviously we're focused on breast cancer, but our trauma survivors having similar issues, or our other, forms of cancer, their survivors having the same issues, and are the same drugs, or are you having results in ways to treat them? Is there a lot of collaboration in the area?
Interesting.
I think from a clinical perspective, yes. And from a research perspective, we do a lot of collaboration with psychologists, and in the understanding of how a cancer diagnosis affects a person, how they think about it. I am constantly talking about trauma with patients, and referring folks to specific types of trauma-focused therapy, to help kind of to just disassociate some of these issues. One of the emerging areas that we think about too is early life trauma. So there's a nice article by a woman whose name I'm unfortunately forgetting because I'm having my own lapse, where that talked about how early life trauma can set up a brain for being a little bit more vulnerable to the impact of the emotional impact and the cognitive impact of the cancer diagnosis and cancer treatment. So those individuals might be a little bit more vulnerable.
We talk about that in our groups, actually. We do. How people learn to process loss. And
well, in early life, they're the networks for coping and for managing stress, and this isn't even necessarily conscious, right? This is just the network in the brain, the way that they've formed over time through early life experiences can be a little bit different.
Right. Yeah.
So, and that that at the time is adaptive for whatever's going on in that person's life, but then over time can be maladaptive. And so, trying to appreciate how a coping strategy may or may not be the most helpful thing right now.
Exactly. Yeah. Well, if you ever come across it, I would love to see it. But we do, as part of our emotional wellness, part of what we do is we look back at things that have happened previously in life and how we dealt with them, and if that worked well, and ways that we could have maybe improved that, and how we're dealing with this, and ways that we maybe want to improve how we're dealing with this, and how we best want to work forward. It's an informative process, I think.
Yeah, no, it certainly is.
People in here have been through the process, but yeah.
Because you bring your whole life into
Right.
the
It's
diagnosis.
not-
You're bringing, it's not
just one event.
right.
It's part of the whole you.
Right.
You're not just your diagnosis.
We
Okay.
did have a question come in before the call today, and I wondered if
Oh,
you
yeah.
could address this. Somebody, one of our participants that said they used to be an avid reader and they're struggling now to read. And,
Yeah.
I emailed it to you since going through various treatments.
Mhm.
Yeah.
Yeah, no, Ashley, I'll take it if unless that sounds good.
I was just gonna say, I've heard that a lot from
Yeah.
people in the research, like about, I've read something and I'm like, I whatever's on the page, don't even know, gotta reread it. So, but I'll let Kat take the rest of that.
I mean, yes, exactly. Yeah. Just like Ashley said, it's certainly not an uncommon experience. And what I imagine is that the difficulty manifests as apparent in reading, but that it might be common. It might be a common difficulty in other individuals who are trying to do other types of cognitively challenging things. And what we tend to see is that it takes a lot more energy to focus and to sustain focus in what a person's doing, be it reading or be it taxes or what have you. You know, the amount of energy that it takes the brain to sustain focus is a little bit depleted. And so when we think about that, then we think about, well, how do we manage fatigue? How do we manage mental fatigue? And so being sure that, you know, our batteries are fully charged and that, you know, when we're approaching a task that's where we have to sustain attention, that we recognize when our mind is wandering and we try and pull it back to what we're doing. So increasing mindfulness during the process. But it, you know, reading and reading for a long period of time is a very cognitively, it takes a lot of fuel. It takes a lot of cognitive fuel. So, you know, really just approaching it in terms of like, how do I set myself up for the best, in the best way to do that, to use up, you know, to fill my gas tank and to pull myself back when I need to.
Yeah, we had a comment from Carol on the chat about she's also an avid reader and says that she has switched to audiobooks instead of physical books, and that's helped her with her retention. So if that's a tip that might help others, you know, something to think about. But just, yeah, I think it's interesting what you're saying, like just to give ourselves more grace. It is going to take maybe a little bit more energy or concentration or what have you, and just to be able to say, well, I still want to do this and I want to enjoy this, but I'm not going to read 3 books a week like I used to or whatever. And just that has to be sort of okay, you know?
Right, absolutely. That a lot of it, you know, especially when we're young and we're confronted with these new challenges, it's like, well, I can't do that anymore. And changing the mindset from I can't do that anymore to I'm not able to do that exactly the same way as I used to, but I can still do this.
Yeah. Yeah.
And it's going to take a little longer, or I'm going to have to just take a couple breaks, you know, that we can still approach the thing that we want to do.
Yeah, that's a good compensatory strategy, you know, which you do a lot in cognitive rehab, where it's, you know, what's the problem and then how can I cope with it? And with sustained attention, it's, you know, managing kind of that energy. So taking breaks when you need to, but there's also, you know, things you mentioned mindfulness kind of quickly, but mindfulness training is kind of attention training in a way. You know, you're training your mind to focus on one thing, whether it's your breath, whether it's a sound. We've done some research in meditation and music listening, and people really like listening to music as the thing to focus on, to kind of train that attention on one thing kind of without the distractions. But it's like a practice, just like if you have a physical, you know, injury and you go to PT, it takes a while to retrain those. And cognitive rehabilitation is kind of the similar mindset of, you know, finding things that can help retrain some of those to make it better, not to necessarily make it exactly the same as before, but to maybe make it a little bit better.
And to offer yourself a lot of reward and appreciation when you get one page done in a book, right? Yes, I got it. I got that page read and I understand what it says and it's stuck, right? So, you know, really giving yourself a lot of reward when you complete something in a stepwise manner along the way, not just at the end when it's all done, but along the way. You know, being your own cheerleader in a sense, which is, I've been through PT, and that is exactly what physical therapists are like. They're like cheerleaders. They're like, yes, you moved a quarter of a centimeter. Yeah.
Yes.
Or get a squad who will cheer you on.
That's right.
I mean,
That's
you
right.
you need your people, I think, who understand how hard some of these challenges are. Because
Yeah.
an adult woman, I can imagine it'd feel a little hard to cheer yourself on for reading, but I mean, you deserve it because it's hard.
Yeah.
There was one question about dementia that I saw in the list of questions that came in that I just wanted to address, because I get this question a lot, and it's really important, I think, to make sure that we draw a very clear distinction between cancer-related cognitive impairment and dementia. They are not the same thing. And the good news is that there is not really solid evidence to suggest that cancer-related cognitive impairment puts a woman at greater risk for dementia later in life. And so I tend to see, especially in older women, but even younger women who are, you know, in their early 50s and are like, is this AD? Is this Alzheimer's disease? It's like, no, this is not Alzheimer's disease. You know, this is something that's distinct, has different causes, and is not necessarily going to put you at risk for a progressive problem later. So if they're like, that's where another area where neuropsychology and getting an assessment can be really valuable, and just reassuring folks about what's going on, that this is not a dementia process. And that the experiences are probably stable, that they're probably not going to get worse like dementia processes do. So these are very different things. So I just wanted to put that point out there to hopefully be reassuring to folks on the call.
Yeah, that's a great distinction. I also wonder about the assessment that you mentioned. Could you tell us more about that? Is it like a baseline, and then would you go back in for measurement or test, or how does it work?
Absolutely, yeah. So you can do serial testing. So essentially you get an initial testing at some point when the problem comes up, and the evaluation is several hours long. It takes a while, but that's because we do a lot of really long and intensive tests, because we're trying to get at what's going on. And then there's a feedback and report where we talk about the results of the testing, and we look at every aspect of cognitive function, or many aspects of cognitive function, I could say: memory, attention, organization, inhibition, you name it, we look at it. And then depending on the results, there are certain recommendations that we can come up with. You know, someone is having trouble learning something when they just hear it once, but if they hear it more than once, they're completely fine. So what does that say in terms of your ability in day-to-day life? Maybe you need to repeat things a little bit, or hear something more than once. And then after that, having that evaluation, and then doing serial testing, you know, every 2 years, every 3 years, every 5 years, to just see if things are stable, see if things are kind of consistent, and or if there are any changes in either direction in, you know, later on in life. Can we see those differences on testing? Can we see those improvements? Or can we see those declines?
Do you know if that's usually covered by insurance if someone's gone through cancer treatment?
So knock on wood, that has been covered in 90% of the cases that I've seen. Sometimes it takes a little bit of advocacy, either on the part of the patient or the part of the referring provider, to just be like, hey, this is important, this is relevant. I've had to get on the phone with insurance companies and be like, what's wrong with you? This is a real thing. You know, cover it. And then Medicare covers it.
Okay.
So anyone who's on Medicare, it's covered.
Well, and then Medicare usually opens the doors to most
Right.
companies, so that's a great thing, because they pick up the tab. All right. So could we talk about some strategies for those of us on the call who are having some of these issues? I know in your Keep Her Breast blog, you had talked about like some websites and different ways that we can try to beyond, like, I know there was music, and I'd seen Ashley had a blog post up right on cancer.org, which was my go-to source when I was going through treatment. Wonderful source of information. So I know maybe we could talk a little bit about music, and there's other, you know, apps or websites just for us to maybe work on our cognitive skill a little bit.
And particularly, if you don't mind if I add on to that, you had mentioned mindfulness already, but Kathleen, in the talk that you sent Len and I that we were able to listen to, that you shared with a cancer group in New York a few years ago, You mentioned some specific things regarding like recalling names and foggy, the words on the tip of your tongue, but you can't quite come up with the word. That would love to hear more about those
Yeah.
strategies as
We've
well.
got about 8 minutes left, so maybe.
Okay.
Sorry.
Okay.
We did our pre-call. I told you I want it all. I'm very
Yeah, no,
demanding.
absolutely.
No, I thought we'd wrap up with the suggestions, right? Because we've talked about a lot of
Practical
the
tips.
issues and the validation.
Yeah,
So,
Ashley, if you feel I'll take the word finding because I feel like that's one of the most common things that we hear.
Yeah, go for it. I mean,
we will be posting, Nancy had asked about this, the screen that Ashley shared before. We are posting the Keep Her Breast blog on our website. It was on our social media before. So everybody will be able to see that information again. But if you guys give us hints about that.
So with word finding, again, it's one of the most common things that we hear. It's also very common in aging. And it is typically experienced as kind of like a tip of the tongue. I know that there's a word for this concept. It's just not coming to me, or I know that person's name. It's just not coming to me. And so there's a couple strategies to think about, both in the moment and then in terms of prevention. So in the moment, if you're able to reflect and find sometimes the word will come to you, sometimes it won't. Honestly, what I typically tell patients is that if the word isn't coming to you, just get the information across, just express the information however you can, talk around it, because you're trying to avoid getting stuck in a loop of just what is that word, what is that one word. If the goal is just to communicate an idea, then just communicate that idea however you're able to. And there's some neuro mechanisms that we can talk about another time. But after you have trouble coming up with that word, usually the word will come back to you a little bit later. And so that's when it's a good time to just try to reflect on the word and say the word out loud, because typically what tip of the tongue or word finding problems where it generates is that there's some kind of compromise between the idea and what your mouth needs to do to say the word. Right? The sounds that need to come out of your mouth and the shape that your mouth and tongue needs to do to say that word. So say the word out loud. Also, in terms of prevention, I also would, like in that regard, suggest that folks read the Science Times or something where there's harder words that are less frequently used, and again, saying them out loud, because you're strengthening the connection between the idea and what your mouth needs to do to say the word. Does that make sense?
Yeah, it does. That's great.
And then with names, the number one thing I would suggest, especially for learning new names, is to say it right after you meet someone. Right? So this is just like 101, like, hi, Ashley, nice to meet you, Ashley. And then when you leave, it's great to meet you, Ashley. I'll see you later. And then just kind of give yourself some time with the name, because names and words, frankly, are random labels and they have nothing to stick to when we hear them. Right? There's nothing on my forehead that says Kathleen, although on Zoom, of course, it says my name on the bottom. But if you met me in real life, there's nothing on my forehead that said Kathleen. So you have to spend a little bit of extra time with that name and try and connect it with something you already know, like a cousin, a famous person, something that it sounds like. Just see if you can hang it on anything that you already know, just associate with something you already know. And that'll make you more likely that you remember it later.
Yeah, I think in general, like with memory, the more senses that you can engage, then the more likely the thing is to stick. So like even if you write things down and never go back and look at them, the act of like writing them down make them stick a little bit more. Even sometimes like just writing it on your hand with your finger, if it's like a name or something, that will stick differently than if it's just, it abstract in your mind. So kind of engaging multiple senses definitely helps with memory consolidation in terms of memory tips. But kind of some of the stuff that was in the blog that we share. So the most research supports cognitive training and cognitive rehab for CRCI, and there's a lot of widely available commercial and also free cognitive training I guess apps and also websites to engage with. So I've been on research projects that have used Brain HQ, Lumosity. I think we have a couple of links on that blog that people can go to. But in terms of if you're struggling with one particular thing, memory or attention, these types of games, some people love them and some people hate them. So if you are a game person and that sounds exciting to you, it's worth trying, because the games get progressively harder, you know, in terms of like, you know, that PT person putting the incline up as you're getting better, the games get progressively harder too. So it's that working your brain and getting harder. And then beyond that, you know, there's some support for mind-body interventions. So things like yoga integrates physical activity and mindfulness and meditation. So that's kind of a good bang for your buck. Physical activity is great for cardiovascular health and brain function. And meditation, there's some support for meditation, mindfulness. We actually looked at a specific kind of meditation called Kirtan Kriya. It's part of Kundalini yoga, and it involves kind of focusing on specific sounds and like using your finger tapping, and basically it's having you focus on something rather than try to think of nothing, you know. So it's like a very specific type of meditation, and we had good results with that. And then we also did the music listening as well, and in a kind of like mindful music listening. What else? I'm trying to think what else am I?
I mean, I'd say, I think one of the big messages too is just a lot of self-kindness, that, you know, when memory lapses happen, just telling yourself it's not a big deal, because at the end of the day, it's probably not a big deal. Just, you know, it happens. It's going to happen from time to time. I'll think of the word later. You know, just try doing your best to not get down, you know, to not feel that the real emotional impact, which I understand is completely valid and completely understandable. But at the end of the day, just asking yourself, like, is this serving me well, to kind of, you know, be done about myself? And if the answer is no, then just trying to move on, and really giving yourself a lot of grace and self-kindness when those lapses happen.
Yeah, I think it's
That's-
important to make the distinction between cognitive abilities and like general intelligence and your life wisdom. You know, those don't change by going through this experience, and cancer-related cognitive impairments are not a reflection of general intelligence or your wisdom. It's a lot of times just accessing that, or, you know, connecting between the different domains in your brain that have become rusty, or those pathways are you know, not working right. So I think that hopefully that's reassuring too for people to hear.
Yeah, and I think that's such a great note for us to kind of wrap up on, just because doing things like this, like, I'm so grateful for the two of you, you know, highly intelligent and educated women studying this and pursuing this field, and really doing the research to try to learn more and help communities like ours. And it really is validating. And also it brings me a lot of comfort to just know we're not alone. Look, I see in the chat, I feel so validated. Like, it's so nice to just be able to say, I think this is happening to me, and you know, and to have somebody else say, yeah, me too, or here's what I heard that might help. Let's try it together. I mean, it says frustrated with the symptoms, but never sure if it was really cancer or treatment related. Thank you for your research and for sharing it with us. So a huge thank you to our guests today. Y'all have been amazing. I feel like we could keep you for another 2 hours if we didn't have other things to do, because there's so much to learn, and it just has spurred so many questions. But we're grateful for the work y'all are doing. Thank you for your time today. We really appreciate you being here.
Yeah, thank you so much. And you do have a wealth of information out. So we will be including some more of your blog posts that we found on our website, and the video presentation will be up on the website if anybody wants to refer back to it.
Are you open to us emailing you, either one of you, if questions were to come up from people reading further? Are you open to that? Okay, because we could also put you in contact with our folks if there's, you know, I just know sometimes when you read the research, you might have something else come up. So, all right, thank you guys.
Fascinating topic. We so appreciate. Have a wonderful day, everybody.
Thank you.
Glad to
See
be
you in
back.
September.
We'll see you.
You too. Thanks for putting it together.
Yeah.
Bye, guys.
Bye.
Bye.